Hi, good afternoon. Welcome to Infinix's next installment of 2024 coding updates and changes. My name is Bo Bowman, and I'll be your host today. I'm the Vice President of Strategic Accounts. We're blessed to have Julie Graham join us again today. Julie's been with Infinix a couple of years now and serves as our Senior Coding Manager. She helps oversee audits, coding services, and works closely with all of our clients on any coding education and services that may be needed. So just want to introduce Julie and let her say hello. Julie's a certified professional coder, certified cardiology coder, and soon to be a certified interventional radiology cardiology coder. So Julie, we're really excited to have you today, and thanks for being here.
Thank you, Bo. I'm excited to do this again.
Absolutely. So just a reminder, while we're doing the session today, you can drop your questions into the chat. We'll see those live and happy to take those either kind of at the end of Julie's presentation here, and then we can talk through. If not, you can follow up with us either via through our website or through our LinkedIn feed. So Julie, let's just jump right into it. So we titled this one 2024 Telehealth and Diagnostic Radiology Trends in Coding, and what we're seeing today. Kind of what I discussed in our pre-chat today. I just kind of want to roll out the facts on maybe where we are with coding for telehealth. Obviously, telehealth and telemedicine got very popular during the public health emergency. Both in my own world and for our clients, we see patients want to use telehealth services and see their physician or their nurse practitioner from home, given the convenience and the additional safety it offers. So just some of the facts out there today, we're still going to be able to do virtual check-ins. Those codes will still be covered. Remote patient monitoring codes for established patients will be in place. Medicare will continue to pay for audio-only telephone services billed with the correct codes through the end of this year, and then have that extended through next year. I thought an interesting one that I found too was all behavioral and mental health services are now permanently added to the Medicare telehealth line of codes. So that was a neat thing too. Today, you're going to talk to us a little bit about documentation and billing. So I'll kick it over to you and let you get rolling.
All right. Well, thank you very much. So the documentation requirements didn't really change much. The providers just have to be certain that they are meeting the guidelines set forth by Medicare. And so that requires that the medical record reflects that services were rendered via audio video technology, and that should be documented within the patient's medical record. If services are provided via audio only, that should also be documented. And on top of that, the doctor should also state why services were not rendered via audio video technology. It could be that an elderly patient or a patient without access to technology or not understanding how to use the technology, but that is different from the previous landscape or the previous requirements within this landscape. So providers should make sure that either one of those are documented. And then they also must include patient consent. So it should say that the patient consented to receive services via telemedicine or telehealth, or via audio video, or phone. And those consents are actually valid for 1 year. So hopefully providers and staff have been keeping up with making sure that those consents are still valid since the PHE started in 2020. And so for the services as well, we have to think about our place of service, and Medicare has said that, and AMA too, to use the place of service that you would have normally rendered the services, and that is place of service 11. So it should be place of service 11 for either telemedicine or telehealth. We should use modifier 95 on those services, except for with United Healthcare. United Healthcare, their policy states that for their commercial claims that they want place of service 2 or place of service 10, and that the 95 modifier is not required, but it can be submitted as informational. So they use the place of service 2 and 10 to understand that this is telehealth services, as to where others, including Medicare, use that modifier 95 to identify telemedicine, telehealth services. And another thing that I think the reason that they're wanting that the providers to document for the reason for audio only, because before the end of the PHE on May 11th of this year, that was not a requirement, but I think that they're kind of doing that to push providers away from using these codes, because they were not added permanently. Actually, the telehealth codes, the 99441 through 99443, will be deleted in 2025. So I think that that's why they made that rule, to kind of help providers get used to not reporting those services, even though it can be quite easy to use those. So and so new for 2024, if you have your CPT book available, for my coders out there, you can turn to page XVII, and we see that the AMA has created new criteria for telemedicine services. And so we're going to take a look at that. The first criteria is that the information communicated between the physician or the QHP or qualified healthcare professional and the patient is in the synchronous telemedicine service must meet the requirements of the same service in person. So it must be of the same nature and the same amount that it would be if it were done in person, which we know that requires, MDM, either MDM or time. So we need to make sure that that information is still being followed when we're reporting these telemedicine services. The second one is the evidence supports the benefits of performing the service through telecommunications technology. These benefits may include, but are not limited to, the following. So they want to see that the telemedicine services were facilitated to help establish a diagnosis or a treatment plan that may reduce complications, a decrease of diagnostic or therapeutic intervention, decrease hospitalizations, or enhance access to care, such as for rural or vulnerable patients. Now, I just selected a few. There are a few more that are listed within the CPT book, and that's why I encourage coders to go look on the, XVII on that page, and make sure that your providers are aware of the things that they're looking for when these services are going to be billed to support medical necessity, in addition to those documentation requirements.
Okay, that's helpful. That's helpful to understand. Again, just the popularity and utilization of telemedicine and telehealth codes today is, clearly, where we're going as a medical community. So, again, any questions on anything Julie's going through today, feel free to just drop us a note in the chat, and we'll answer it as soon as we can. You want to keep going, Julie?
Yes, sir. So next we're going to shift to some new, or at least one new cardiology code. There are some other new codes, but myself as a cardiology coder, I'm really excited about the new code for the IVL, or as we know it as intravascular lithotripsy in the coronary arteries. So currently we report 0715T for that. So if a provider's in there doing a percutaneous coronary intervention and feels like after he does a stent, or possibly before, he's going to do a lithotripsy, we report that currently with, like I said, the 0715T. However, that code will meet sundown here in 2024, and we have a new code, 92972. And this code can be reported in conjunction with, as you see here on the screen, with a PTA, atherectomy, a stent, MI, chronic total occlusion. And so we see the codes that, if you look in your CPT book, it'll list these codes that you can report the IVL with. And the RVUs on that code are 2.97, which equals to a payment about $140, which this is great news for providers too. I'm sure providers are going to be extremely excited about this because I see this code being utilized more and more and more since its induction. And as we all know, as coders, with these T codes, with these category 3 codes, they can be cumbersome. They're hard to get paid at times because you have to submit a comp code, or you have to use a comp code to determine your payment. And then you have to submit medical records. And so it's a very tedious process to get that paid. But now we have a category 1 code, which will eliminate that administrative burden, that AR burden, and get more revenue for the providers, which is always good news, always, especially with the cut this year to the conversion factor. So I think providers will be really excited about that. Another benefit that I think doctors are going to be really excited about, I'm excited about as a coder as well. Medicare has decided to delete G2066. Now, this code is reported as a technical service, the technical component of a service for cardiovascular physiological monitoring or subcutaneous cardiac rhythm monitor. So that's for your ILR, implantable loop recorder, or for when the doctor is looking at, or when the technical component of those services are performed. We currently report G2066. So as it stands right now, G2066 is based on contractor pricing, which that is, there's a span across the board because one MAC may pay $30, another MAC may reimburse it at $200. So there's not a level playing field there. So now that these services will become global, 93297 and 93298 will now be global codes, will have national pricing. And so the 93297, there's a payment increase, which again, great news for providers with the reduction in the work RVUs with the reduction to their conversion factor this year. So the payment increase, they're now going to receive $59.27 for 93297, which is up from $25.75.
Great.
So now these codes require, both the 93297 and the 93298 do require that both the professional service and the technical service are both provided. If only one of those is provided, now you're going to use your modifiers. You'll either use modifier 2.6 for the professional component or the TC for the technical component. So that's something to be aware of. So you have to make sure that you are providing the global service. However, from what I see with our clients right now, they will capitalize on this because most of them bill 93297 and the G2066. So again, these are two little, just a little ray of light, a little bit of extra revenue for providers. So that'll be, I know they'll be very, very excited about that.
Yeah, in a time of rate reduction and sequestration, these are great updates. On the deleted codes, what have you seen in kind of how long it takes us as a medical practice or as a billing company for adoption or adaptation? So if we still accidentally use the wrong code, post the go live date, how does that work for the provider? Are they able to recode and resubmit?
Oh, absolutely. It'll just be more of an administrative burden on the back end, and a delay in payment, because then you're going to receive a claim denial. So then it may have to go to a coder to review, or, and then it'll have to go back to AR to submit a corrected claim. So you really want to make sure you submitted a clean claim to begin with, so you're not losing any revenue on, having people do extra work. You want to get it paid the first time, keep that money in your pocket, and add to that. So yes, it's okay if you don't implement it on January 1st, or if you miss it. But I do encourage coders to speak to their providers, prepare them for these changes, which I think most coders are very awesome at doing. That's our job. We're very cognizant of changes and what needs to be done. So I know that the coders out there will be on top of making sure, hey, look, you've got this going for you. This is a new code. We can bill it like this now. And usually when doctors hear that, they don't forget. They're not going to forget that they have a code now that will prevent them losing money. So now there are some clients who are a little bit more, they take a little bit longer to get with the program or to incorporate new changes. But again, you're going to see those denials. So that should light a fire to go, oh my gosh, we're doing something wrong
here. Great answer. I teed that one up and you nailed it.
Yeah.
Perfect. All right, let's shift gears a little bit.
Okay.
On the RCM side of what we do with Infinx and all of our clients, every single monthly meeting we have with some of either our cardiology clients or surgical client, we get into when the codes should be bundled and versus unbundled, and
Yes.
it's kind of constant confusion. So I see we're going to talk about VAD here. Do you want to kind of walk us through an update for us?
Yeah, this one I included because, and this may be old news to some coders. And then there may be some coders who did not know about this. I kind of felt like this was a silent retro.
Okay.
Retro, not a retro auth, my bad. That's a typo. A retro edit for this year. Prior to this year, you could not report an RVAD with an LVAD. So that's a left ventricular assist device with a right ventricular assist device. And doctors were not happy about that. One of our clients, our providers was not happy about that because, these are devices put in two separate areas for two different reasons. And so they felt like they should be reimbursed for it, which they should. And so many people got together, many different providers, many organizations, your ACC, other ones got together and contacted, I think it was Medicare on this, since this was an NCCI edit, and just kind of stood, pled their case. And so we do see that there's a retro edit effective for January of this year. So now these two codes can be reported together. It's not in all common. I've seen it more and more lately. Typically, you're going to see one or the other, but now providers, if the patient is ill enough or has clinical indications to warrant both of those, they can now get paid for both, which is, again, great news for providers. They should be paid for the work that they do.
That's
Yeah.
great. Okay, and then on to EKGs.
So this one, again, it may be something that, some people, this might be more common knowledge, but I do see it sometimes in audits, in reviews and denials where where a routine EKG is reported with a device. So like, when we have our pacemakers or our ICDs, that's our cardio defibrillators. They do, the doctors will either do programming and interrogation. Those can be done either in person or remotely. And so anytime you build those, an EKG is included. That these devices already are looking at the electrocardi, the electric activity within the heart. And so, and as a cardiologist, anytime a patient comes in, they always do an EKG, right? That's common practice in cardiology. So when the patient is coming in for a device check, be it interrogation programming, being in person or remote, or in person, unless that EKG is the reason unless it spawns, like the doctors say, oh, something's going on here, I need to now interrogate your device and see if it needs to have any programming, then you can report that routine EKG with a modifier 59 or an XU with if it's for Medicare. So if the patient is scheduled for those, often these are just scheduled because you can bill them every so often. So they're typically just scheduled. And so in that case, you don't want to report an EKG in addition to those because it will bundle. The edits do allow for specific situations, which this is one. There are, for different for different procedures, there are different reasons why you can do things. So you just have to make sure that if you are using that modifier 59 or the X modifiers, that you are actually meeting that criteria and those guidelines to do so.
Good knowledge to have. Okay, we're going to keep rolling here. Going to get into some procedures for diagnostic services. What do you want to summarize here for us? What's most important for folks to know?
Well, I think that here you just, it's important to remember that with these interventions, with either the percutaneous coronary interventions or the endovascular revascularizations, that those diagnostic studies are included with these codes, unless you meet criteria that I've put on the slide here. So the criteria is outlined on page 754 for the cardiac, when you can report cardiac cath with the PCI. And then you have on page 536 through 537, when you can report an angiography or an aortography with the 37220 through 37235. But I know a few of those off the top of my head. So obviously, if the patient's never had any type of diagnostic study, which does happen, the patient's coming in the office, the doctor's thinking, oh man, I really need to see what's going on in here. So they have no previous study. That absolutely meets your definition to use modifier 59 or the X modifier for Medicare. However, if they've already had a previous study, that's when you really have to pay attention to the criteria. The criteria states that, so if there's a change to the patient's clinical indication prior to what was already decided, then yes, you can. There has to be a clinical indication, though, a change in the patient's clinical indication. And so doctors need to be very cognizant of that and make sure that they're documenting that change in clinical indication to support the medical necessity of reporting another diagnostic study. There's also, if the patient's health changes during if they're in there doing a PCI and the patient starts to code or whatever, there's some other reason where the doctor's like, oh my gosh, I need to see what's going on. I need to get back in there and do another study. Again, that can be done, but there will need to be pretty specific documentation that will support that medical necessity, because sometimes payers will, they'll just accept the 59, but we're seeing that payers are getting a little bit more strict, a little bit more stringent with that, and they are asking to, well, let me see the records, send us the records, let us review it and make sure you're actually meeting the qualifications to report these modifiers. So
yeah, there's no doubt the amount of work that our billing teams are spending now to go get the additional documentation and resubmit, and make sure we're resubmitting the appropriate documentation with the appropriate code at the appropriate time. We've just seen really heavy influence on not allowing the claim to go through. So hopefully all important for those listening and for our clients to know that our goal is to get the claim through right the first time, and every practice should feel like that. But this coding piece is where it all starts.
Yeah. And another little thing I put on here that I think is really important, Medicare, they love to be different, do things their own way. They're, march to be their own drum. So they actually consider a CT or CTA a prior based angiographic study. So be aware of that. You may not see an aortography or a lower extremity angiography, but if the patient's had a recent CT or CTA and they're a Medicare patient, Medicare will consider that as part of their the angiographic study, and so you cannot report modifier 59 for doing more studies at that time, unless again you meet that criteria. And so another good thing to keep in mind is when you're looking at bundling, if a code has a 0 edit, it means that it cannot be reported with that other code. There is no modifier allowance. There's no way you can override that edit. If it's a 1, if it's an edit of 1, then you can look to use those modifiers to override the edit. So you have to be very aware of when you can and when you can't. You don't want to submit a modifier when it's a strict no-no.
Okay. Well, hey, Julie, thank you so much for your time today.
Yes, you're
I
welcome.
think this has been a great summary. I know it's going to help both clients we have now and clients in the future. And as you can see here in our conclusionary slide, if you have any questions, you can always drop us a line on the chat here, or you can follow up with us at our website, www.infinix.com. And again, as a maybe a potential interest in how your practice is doing, regardless of specialty. Couple of ways we would like to engage, and one, we can do just a full coding audit. We can look at the last 12 months for either at the macro level for your entire practice, and bump those up against our Medicare norms and help kind of grade providers on where they've done in their coding performance, and then come back and provide the necessary education. We can do that in person, or we can do that virtually. Another nice tool for a potential client to receive some services that we think helps the overall health and fitness of the practice, if you will, is what we call a health check. So if you'd ever be interested in that, please reach out to us on the website. And we'll set up a call to walk through what we do in the health check and how we look through the entire RCM cycle for you and your providers. Thanks again for the time today.
Yes, thank you.